Noga Arikha, nice to see you. Congratulations on the book, The Ceiling Outside, The Science and Experience of the Disrupted Mind. Let me give you a proper introduction. Noga is a philosopher and historian of ideas. Her previous book is Passions and Tempers, A History of the Humours. She's Associate Fellow at the Warburg Institute and Honorary Fellow of the Center for the Politics of Feelings in London and a Research Associate at the Institut Jean Nicod, if I pronounce that right, in Paris. She's based in Florence, Italy, where she is now. Welcome to the show. Hi, nice to see you.
Thank you so much, Michael. It's great to be here on this show.
What's this? We'll get into your book big time, but what's the previous book about? I haven't read that. Passions and Tempers, A History of the Humours.
Yeah, well, that's a book from it was published in 2007. It's basically a history of the humoral theory that prevailed for 2,500 years in the West, from the Greeks to basically today, tracing the continuity of one idea over a long time, despite big changes. And it was already a way of looking historically at the mind-body issue, right? I mean, that's of how the humors being this idea of the substance in the body that conditions all psychology and all mental and physical health. It was already of looking why this idea persevered. So I was already interested. I mean, as a philosopher, the mind-body problem was what interested me mostly, let's say. And then I decided to go into the history of ideas about these things to get out of this tail-biting exercises of purely conceptual philosophy. And then I gradually, as many other people, became more and more interested and obsessed in a certain way with the science, especially as it's developing now. So we'll go into that. We'll have time to talk about it.
Yeah, for sure. Well, you mentioned in your new book, you were studying Descartes in high school because people in France have much better public schools than we have in the United States. I fear I studied girls and sports in high school, and so I didn't even know there was such a thing as philosophy until I got to college. It's like, what is this again? Existentialist? What is that? So give us a little bit of background. What's your story? Where are you from? Do you have siblings? What's the influence of your parents, particularly since you talk about your mom in your new book?
I do talk about this because it's obviously a very important part of what I'm trying to talk about is what happened to my mother as well, which is she developed dementia at the end of her life, and I realized so many people do. It was a responsibility to talk about it. I was living in Paris until a year ago, where I actually grown up, but my parents were not actually from there, but we spoke English at home, so it was a very Anglo-American kind of household and culture and intellectual culture. I did all my studies in England, and I was in London for 13 years, and in New York for about 9, where I went after my doctorate. I did my doctorate in London at the Warburg Institute, actually. And then was in New York, and then where I wrote my first book. Did a whole bunch of things. Had my kids, one born in New York, the second born in Paris, where we went 10 years ago. Well, now 11 years ago. We spent 10 years. And now here I am in Italy, which has been a kind of constant in my life for other reasons. But that's not interesting for what we have to talk about. Though in a sense, yes, because in a way I'm deeply European. It's a very European history. My father was a concentration camp survivor. There's very Jewish European history with some American put in there. So I am a kind of mix. So I've always mixed things, mixed identities, and also mixed disciplines. I think I've always wanted to do that. It's a kind of neurosis to want to mix things and never to want to be in one place, which I've now, I suppose, tried to turn into a virtue, as most of us have to do at some point, turn our weaknesses into strengths. Well, not weaknesses so much as complexities into something.
Well, being a scholar of the history of ideas allows you to bounce around in a lot of different topics and integrate them in ways that more narrowly focused scholars can do, I think. And that comes out in your new book, which is very poetic. It's very literary, the way it's written. But I'm glad you nudged me to look into the Endnotes, because I had just listened to the book on audio. Of course, the Endnotes aren't in the audio edition. But man, the Endnotes section is impressive. That's a lot of... I know that science pretty well. Probably half the references I never heard of. So really important to look at that, I thought. So let's start there. You started this book. You were interested in the embodied mind. You talk about Antonio Damasio, who I've had on the show. He's a super interesting guy. this
Yes, we just had a
idea
conversation.
that oh, you did. Oh, nice.
We did, yeah. Through
the brain serves the body rather than the body serving the brain. This kind of idea. So you start in writing about this, and then all of a sudden your mom starts deteriorating, and so you have a different sort of thread for your book. So talk a little bit about that.
Right. So yes, exactly. So I am. I mean, in a sense, it's true. I mean, I'm interested in many different things, but the most centrally has always been. I've always been most really interested in consciousness, the self, the embodied self, human or animal, as a matter of fact, really at this point. I wanted to get deeper into. Let's say how the self or how consciousness, so to speak, can be disrupted, really, through neurology. I got first, and I wanted to understand from close up what was going on with neuropsychiatric patients. I had the opportunity, thanks to a neurologist at a hospital, to just sit in on these extraordinary sessions. And these sessions were once a week. The classical clinical meeting, weekly, that the French call, in good French, le staff, the staff meeting. And this was a unit, which no longer exists, of neuropsychiatrists. So, I mean, of neuropsychiatry, meaning of neurologists and psychiatrists speaking to each other. There is no such thing as neuropsychiatry as a discipline officially anymore in France. So they really wanted to talk to each other because they needed each other. They realized to try to diagnose these particular patients who presented with complex, not very clear difficulties. And so I was able to sit in for 18 months, once a week, more or less. I was there, and these sessions lasted about 3 to 4 hours in the morning. Wow. And they only 2, maximum 3 patients were discussed, examined, and then tried at least some attempted diagnosis was made. So it was an exceptional amount of time, an exceptional focus of attention that should be the paradigm for all health practice, and of course is not anywhere in the world. And as I said, this unit does not exist anymore, but for reasons I'm not aware of really. But it existed for a few years. And I had the privilege of being able to just to sit in as a fly on the wall. I never saw a patient more than that one time. I never recorded their names, so I invented all the names. I changed the life details, obviously, to keep everything completely anonymous. They were just saw me as one of the people present. Other people present, there were very few. Were a few residents, a few students, sometimes some external people like me, the senior physicians, and that was that. Maybe 12 people in the room. It was very intimate. So I did this, and then out of those many patients I did see, I selected those that seemed to be most, to present with the most difficulties that were most significant for my questions about the self, about the sense of self. I excluded those whose stories were really too horrible, because that would have been unnecessary, voyeuristic, and wrong. And I then started writing about them. And then in the meantime, I'd become extremely absorbed in the science of, I'd written a piece for Eon magazine as well on interoception, this called the interoceptive turn, this extremely important shift in the cognitive sciences, the neurosciences and psychology, to the sense that the brain cannot be looked at on its own, that is its constant conversation with the rest of the body, indeed that it serves the body. That the notion of the brain in the vat is completely absurd, that we are basically biological through, and ourselves are deeply embodied. I mean, you cannot think of the mind without the body. So I wrote about this. I did a lot of research on this. I've become quite, conversant. I mean, at this point, I follow the science very closely. I'm friends with many of the scientists who are doing this. I think they're doing very important work, which is, it's true, as you mentioned before, revolutionizing the Cartesian paradigm that so many people grew up with and still have. That is this idea that mind and body are separate, which was what Descartes had said, the kind of so-called foundation of modern philosophy, that there is such a thing as an immortal soul, right? That a lot of people want to believe that sort of thing. And in fact, well, it's really hard to accept that it's not true for some people, but I think it's hard to accept that it could be. So it's not surprising, speaking to the skeptic. And so Descartes, was, in a sense, this was the mind-body dualism, which I say in the book, and it's something that is true. It gave way later to what's one calls the mind, the brain-body dualism. So we accepted that the mind is in the institution of the brain, but we forgot the body, which is why then you had all these, philosophical thought experiments of the brain in the vat, and what happens if you transfer the brain to another body, which is a fun idea to play with, but it's absolutely impossible to. It's really just a game.
Yeah.
And so that science really fed deeply into my analysis of what was going on with these patients, knowing that in the clinic there really was very little of that science present, if at all. There's a gap between neurology and neuroscience for obvious reasons of disciplines, of time, of availability, of professional, training. It's in a sense inevitable, and also for another structural reason, that neuroscience, as I also say in the book, neuroscience is dealing with the generic healthy brain. Well, now that's changing. Whereas neurology is talking about the individual patient who is ailing. So how do you put the two together? Now, again, there are many more people doing that now, but it's slow. And certainly in that clinic, you didn't see much cutting-edge science being thrown at the patients simply because, or the analysis of their cases, rather, simply because you just can't do everything. The physicians I was in presence of were extraordinary, I have to say. Extraordinary clinicians, and seeing such clinical attention at work is a mind-blowing experience. And I've always had a great passion for medicine as much as for science. They are different things. So, and then, number 3, as I was writing, as you mentioned before, I realized my own mother, who had already been showing signs of confusion, really was developing clear dementia. And that I could not exclude her from my story because there were patients I saw who were about to develop dementia or had it. Because indeed, what was happening to her sense of self, the question was very pertinent in my own life. And it would have been hypocritical, it would have been also a lie to write a book with as if this was not happening. And what helped me decide it was okay to do so, because I did hesitate, was, well, first this idea coming from phenomenology, the philosophical tradition, which is really anti-Cartesian, which is the idea that you cannot study, that the subject has to be present within any kind of study of the object. The subject, in a sense, is what we are. It cannot be abstracted. It must be fully there. So abstracting myself really would have been wrong. That's number 1. And also number 2, I realized, well, again, as I said before, the fact that so many people develop dementia, it was almost like a way of, well, seeing how my experience could be of some sort of help, or I don't know what, to others, and also how I could honor my own mother by doing so. Because my mother was a poet, been a poet, a writer, an intellectual all her life, and she had therefore what one calls a lot of cognitive reserve. She had within this dementia, she lost her episodic memory, meaning her long-term memories, but her verbal sagacity was extraordinary, and she said amazing things. And there was a poetry to her being, and her emotions were not affected. So she was still present in some way. So we'll talk more about that too. Therefore, so that's it. So all these levels helped each other, in a sense, the patients, the science, and my own experience, and my mother, all this fed on each other. So,
I really loved your book because of that. Most neuroscience books and consciousness books that I read are about, the generic human, the generic brain. or whatever. And I love your work and that of Oliver Sacks, who you reference, because it's not about, the generic brain. It's about that person's brain right there. That guy, he's having this particular problem. Why is that? And also, I just want to get your sense of what these hospitals are like. I think most people have an image of a mental hospital that comes out of One Flew Over the Cuckoo's Nest, which was Ken Kesey's attempt to show, we have a problem here. These places are pretty grim. And I remember when I was an undergraduate at Pepperdine University in Malibu, I took an abnormal psych class, and we had to do a internship at Camarillo State Hospital up the coast, and it was just like right out of Ken Kesey's One Flew Over the Cuckoo's Nest. I mean, it was grim. I thought, I will never go into clinical psych. This is terrible. And so it sounds like the place you were at was way, way better, much more humane.
It wasn't a mental hospital.
So
the Pitié-Salpêtrière is one of the largest hospitals in Europe, if not the largest one. It's a huge hospital. It's a beautiful campus. And this was just one unit within the Center for the Study of Nervous System, with lots of different departments. It was almost like a university campus, really. It's not specifically a mental hospital. The psychiatric clinic in Paris that is most well known is Sainte-Anne, which is not at all grim. But it's not this. Pitié is this very large, really quite wonderful place, full of activity and very good medicine. Yeah. And that unit was,
what's your sense
it was not, sorry.
Let's say, since you do history of ideas, what's your sense of progress in treating, say, schizophrenia or dementia or Alzheimer's, or any of these brain disorders? How far we've come, how far we still have to go?
Well, again, so schizophrenia, I think, there's in psychiatry, right, which is different from neurology, right? So we'll talk about, I should say more about this. Actually, before I answer your question directly, I will say more about this. I think it's important. The Pitié-Salpêtrière Hospital was the ground upon which neurology and psychiatry really had important moments in their development, and where they separated. They weren't apart at first. It was a study of the brain, mind. What happened was, more or less at the time when Alzheimer himself discovered those rogue proteins, so to speak, responsible for then what we know of the Alzheimer's dementia. You understood that there was an specific organic lesion responsible for the disease. Whereas in psychiatry, there's no visible organic lesion. You don't really know what's going on in the brain. Now, things have changed today, and this is why this neuropsychiatry clinic was important. This is why neuropsychiatry needs to reform as one, perhaps. Insofar as what counts as organic or not is no longer the same as what was the case in the early 20th century or late 19th century. Now we know that most ailments of the mind do have some kind of organic basis. We just don't quite know always what this organic basis is. Now, Freud wasn't at that one point on the Pitié campus. He worked with Charcot. He translated him back when he returned to Austria. And he himself was a neurologist at first. Let's not forget that, right? And he then the reason why he left neurology because he realized that the mind science of this day was not sophisticated enough to give him the answers to the questions about the self that he had. And that's why he developed then the psychoanalysis. But on the basis then initially of the study of hysteria that Charcot was very famous for doing with the help of photography and so on. The story has been told many times in many books. I do tell it at some points, in some level in my book as well. It's a very important part of the history of all this. So there is still a kind of, again, this unit was formed because there is a kind of no man's land between neurology and psychiatry. And many patients, many of the patients I saw were patients who have what one calls functional diseases. It means you don't really know what's going on. We know something's going on. We don't know what it is. That includes chronic pain. I think 1 person in 5 in the US has chronic pain, actually worldwide. Includes all sorts of ailments, like IBS is a functional disease. All sorts of what one calls today conversion disorders, which were called hysteria at some point, which can all be called, which have now different kinds of names. Those are in between. We don't quite know what they're about, but they're definitely about the brain-body messaging. And they're certainly about some interoceptive issues, which are now being studied, but were not yet present in the clinic. Those are the issues I was mentioning. So schizophrenia, there's many theories of what's been going on. What's interesting also is that the medications that have been developed for psychiatric disorders, such as schizophrenia, target neurotransmitters primarily, but we don't really know. A lot of the time, we don't really know what they're doing, why. They do help. They do help. So I would be the last person to say, no, psychosis is, can be helped. The problem is, of course, that these medications have all sorts of medical side effects, which are very unfortunate, very often. So it's not yet there. The root causes of these issues are still not, they're being highly researched a lot. We just don't quite know yet what's going on. But there are many hypotheses that are coming out also of the interoception research, which really need to be brought into the public realm. And I think it's starting to happen. Neurological diseases such as dementia are specifically neurological. There really are, as one neurologist put it during a session when I wrote that down too in the book, he said we could just call them all proteinopathies, meaning they're pathologies of the proteins in our within the neurons. Like for example, in Alzheimer, it's certainly tau protein is responsible, but not only. There's all sorts of other things going on. There are all sorts of other theories. Every day there's a new one. There are billions invested in dementia and specifically also Alzheimer research. We don't yet have answers. We don't yet have treatments. But it's ongoing. I think that we will. But there are many, many theories. Not all of them are compatible with each other. Medications that are presented suddenly as a possible solution, which a couple of years down the line show themselves to not do anything. There's a lot of that going on too.
Yeah, there's periodic stories here of new drugs to treat Alzheimer's, and then you just don't hear about it anymore. And then you read stories about you can help prevent Alzheimer's if you do Sudoku puzzles and you read and you journal every day or you exercise every day and all this stuff. And then nothing ever comes of these things. It just seems like a really hard problem. But on that distinction you're making, if there's an obvious neurological problem, a tumor, an injury, a stroke, something like that you can see in an MRI scan, it feels differently than when you can't see it, right? But it all has to be neurological. It all has to operate on the machinery, right? Even if it's a purely environmental cause and there's no genetics whatsoever, there's no tumor, there's no lesion, but it's still operating on the machinery. Where else would it operate, right? So it has to be neurological at some base level.
Yeah, it's organic. And it can be a whole host of things, absolutely. Those lesions, those things you described, like stroke, tumors, and so on, I have to say, those are the areas in which neurology has made the most progress. Neurosurgery is extraordinary, and there are books by neurosurgeons and about neurosurgery. That progress is extraordinary, and it's kind of wonderful to see. Stroke really can be reversed. Effects of stroke can be reversed. There are treatments. There are ways of dealing with these things. Vascular neurology is definitely, in a sense, more amenable to treatment than these other broader, less localized ailments. Yes, for sure. But yes, they are. Something's happening. We don't quite know how. But even in the case, there's more and more work now in the interaction between the central nervous system, the brain, and peripheral nervous system, which is the rest of the body, and also the gut, for example, the immune system. All this stuff is interconnected. So, and heart, of course. So the viscera and the brain are interconnected in ways that are being, as part of the interoception research, they're being more and more understood. There's a lot to do, but every day there are new papers coming out. And so, it's in the machinery, as you say, but yeah, it's not just the brain, right? There's a lot of things happening. There can be states of inflammation throughout the body that may be informing then, can actually cause responses at the cerebral level. That can happen. We just don't quite know the whole story, but there's a lot. I mean, if you had a scientist right now talking to you right now, they would be able to tell you much more in more detail. But I'm not a scientist, so we can also talk about this. I mean, I'm just a humanist who reads a lot of the science and feels passionate about it. But I still think, and this is really important, that just as we non-scientists really do need to learn how to read science, learn how to understand scientific processes, which are never the full story. There's no such thing as an end story in science, right? People get confused about that. I'm actually involved in a project right now, in a Munich-based fellowship on the communication of science. And we're understanding that if there are people who reject the authority of scientists, it's because maybe scientists don't really know how to present themselves. They don't know. It's very difficult for people to accept skepticism. And people have forgotten, something you know, that skepticism is foundational to the creation of modern science, right? 17th century scientific revolution was based upon, explicitly based upon skepticism, revisable knowledge, get rid of dogma. There's no such thing as a last answer. It's constantly open. It's all provisional. And so we need to learn how to read the science. We need to understand what statistics are. We need to understand what these studies are. We need to understand that. That's very important. On the other side, the scientists also need us to help understand what questions need to be asked, what answers are not answers, and so on. So all this dialogue, I think, is very important as a dialogue. And I'm very invested at this point, in especially now with this book out, I'm very invested in trying to help develop this kind of interactions, conversations. Again, there are many more and more of them happening, but I think the conceptual aspect needs to be refined, right? Because there's a lot of, we need to understand what's stopping this communication. The very different kinds of rhetorics and discourse, A novel, a poem is not a scientific paper, nor should they be. But what can the two have to do with each other is a great question. And I tried to do that in the book as well. I mean, this is where the first person is really inserting herself in the study of the other.
I think of science as a three-legged stool: data, theory, and communication. You need all three.
Right.
Unfortunately, historically, the communication part has always been thought of as like dumbing down. You just write for the public, that's not serious. Serious scholarship is you just write these obscure papers that no one can understand for 12 other colleagues. And it's not dumbing down. It's a skill to be able to write clear for anybody to pick up and read these kind of what John Brockman calls third culture books.
Exactly,
like
yes.
Origin of Species or any of Dawkins' books or Pinker's books, your books. Anybody could pick them up. And these are not the pop versions of the serious books. These are the only versions there are. And anybody can read them. And it's a skill to be able to write for your colleagues and the general public so they both get something out of it. And that takes practice, right? And a lot of scientists who are trained to write for scholarly papers or scientific papers, which are pretty formulaic. You have the introduction, the literature review, here's my hypothesis, the methods, conclusions, and so forth. Anybody, it's like laying pipe, it's just anybody could do it. You just show grad students how to do it and they do it, right? But writing, this kind of book, that takes a lot of practice. Anyway, so you open with this story about your mom. She calls you and says, "I can't find your phone number," and you're like, "Mom, you just called me."
That was a lot. Happened a lot.
And then she's trying to find some other phone numbers for this committee. and there's a review of my book on the front page of the magazine. I can't remember the name of it. It must have been my mother who gave me this beautiful scarf. And you say, but mommy died in 1986. Oh, did she? Yes, she did. And she could hardly have bought such an elegant scarf in her religious neighborhood in Jerusalem. And then she says, well, you never know. She could have. People bought all sorts of things. Anyway, this reminds me of Michael Gazzaniga, his work on this this kind of memory disorder where he has this patient who thinks she's at home and she's in this hospital, and the doctor takes her down to the bank of elevators and says, well, how could you be home? Look at these massive elevators in this building. And she says, oh, you have no idea how much it cost us to have those installed in the house, right? So she's just making stuff up.
That's wonderful.
Right? But Gazzaniga says, well, actually, we all just make stuff up, right? It's just all information coming in, and thoughts are bubbling up from who knows where in our brains. And then he has this, what he calls the left hemisphere interpreter. There's this area in the brain, this neural network, that just kind of puts it all together into some plausible story that makes sense, right? So like with his split brain patients, they flash on one side of the brain through the other retina, a can of Coke, and then the person afterwards gets up and, why are you going to get a can of Coke? Well, I'm really thirsty. Oh, really? That's the reason? Oh, yeah. Yeah. So they're just making stuff up. But his point is that we all do this, right? So if I ask you, like I did earlier, what's your story? Where'd you come from? And then you string together this kind of plausible autobiographical story of how you got to where you are today. Okay, yeah, I assume it's true to whatever extent it is, but we all do that. We all just kind of make stuff up, like, how did I get to do what I'm doing today? And I'll tell you some story, but it didn't have to be that way. And I'm just making stuff up based on what I can remember. Half of it's probably confabulated and misremembered and edited along the way, and so forth. And so let's talk about autobiographical memory.
Brilliant.
And what it means to even be a self. Who are you?
So I think that, to talk about this, this is great. So you brought up, in a sense, and then there are two words that come out of this. I mean, one is we're talking about these, patients that have what one calls anosognosia, which is a lot in my book as well, because dementia patients, I mean, not all, certainly Alzheimer's, there is this anosognosia, this inability to understand that you have an illness, right? So this patient of Gazzaniga was one of them. And on the other hand, you talked about confabulation. Just now you mentioned the word confabulation, which is, of course, connected at some level. But, and I agree, we all do that. We all do this, and at some, and I, initially, and I thought at one point that the center of the book, the center of gravity, should be anosognosia as the human condition, right? Because we are all always, blind to ourselves. Whatever we do, well, to some extent, is actually not true. It's actually not entirely true. It's true that we don't really see ourselves. We don't really, but there's a huge difference between the ordinary neurotic blind spot and pathological anosognosia. In the same way, there's a huge difference between, inventing, stretching meanings in our lives quite consciously, perhaps, or not, or, but still something amenable to self-examination, and actual confabulation in patients who have some neurological disorder. And so that really brings us to that line, right, between normalcy and pathology, and where is that breaking point? Because it is a continuum, but there was one point where it switches, where that's what happened with my mom. It was ordinary confusion, and then it was not ordinary. There's a point of no return, so to speak, in the case of dementia. But certainly there's a difference between normal and pathological. And I think that we are confused about this precisely because certainly, in America, the DSM has contributed to pathologizing a lot of ordinary human distress. Maybe out of a lack, owing to the absence or to the scarce dialogue between philosophers and clinicians in this case. A lack of philosophical questioning about what constitutes pathology. Because it is a philosophical question at some level. Is mourning, who determines that your extended mourning period is pathological? Alan Francis, the psychiatrist, who was the chair of the DSM-4, was very, very critical of the DSM-5 because of actually one reason was the inclusion of that form of disorder and others. So there are many problems which are, I don't know what to call them. I mean, they're conceptual, they're confusions, they are maybe sometimes political, I don't know, but there are definitely ways in which we also need, I think also psychological and sociological, we need to have solid answers. We need to label our disorders, we need to label our unease. Because if we have a label for it and somebody tells us it's pathology, it's not normal, then we'll sometimes feel better. But is that really always the case? And does that really do us a service? I mean, that's an open question as well, I think. The history of medical labeling and psychiatric labeling is complex. It's also, again, it's also true that there is this continuum, and I agree. I mean, I think, and as I say also, well, we all know we're all potential patients. We're pretty fragile. I mean, we're pretty resilient, but we're also pretty fragile, this both. It doesn't take much to wipe out our whole memory, as the first patient in the book, Vanessa, as happens to her. And, she wakes out of this hypoglycemic coma, aged, she's 36 or something when she has this, and she wakes up having lost 10 years of her life. How did that happen? We don't quite know. It's definitely pathological, although when I saw her, she came across as a completely normal person, perfectly functional. So these questions are quite complicated. And what happens to us, to the sense of self, in these cases, is complex. There's another element, which is the self and memory, right? Which is another thing. I mean, as you were saying before, we can confabulate about have a memory that we actually didn't have. A memory of something that didn't happen to us. But it's not confabulation. It's misremembering. And we do it all the time. Memory is not at all a seamless thing. It's a process, dynamic. It's never fixed. And so we are constantly creating our meaning. And I think what defines us as humans is the need to create meaning, autobiographical meaning. To get back to what you were starting with before. I mean, we need to do that all the time. And even when we are quite ill, it's true. I mean, like in the case of the Gazzaniga's patient, in the case of my mother, we need to have some kind of coherence, always, for reasons that also can be, interrogated.
Mm-hmm. Is it your sense that it is a continuum or a spectrum, but at some point, a quantitative difference or decline in memory becomes qualitatively different when you hit a certain line? As they say, if you can't remember where you put your car keys, that doesn't mean you're suffering from dementia. But if you hold up your car keys and say, "What are these for?" you have no idea what a car is, then you probably have dementia.
Yeah.
So where is that line? And is, the diagnosis problem seems pretty important. It's kind of the social nature of science that you have a committee or a group of people that says, well, we've decided if you have 8 of the 12 of these symptoms, we're going to call this schizophrenia or whatever in the DSM. And so there is something of a subjectivity to it, but at some point there's a biological factor at work, and you can kind of track it quantitatively and say, there, at that point, there's a pathological problem.
Absolutely, yes, absolutely. And I saw that in action in the clinical room. I saw exactly how they were conducting their examinations. And it was fascinating. I mean, so starting with the anamnesis, meaning the medical history of the patient, presented very detailed way, with a kind of, with the history of pharmaceuticals, what are the doctors diagnosed with episodes, and the chronology being extremely crucial. I mean, those patients for whom chronology wasn't clear were the hardest to diagnose. And then when the patient came in, sometimes with family, there are all these stages of examination, starting with, what brings you here, to see what the patient themselves, what awareness the patient themselves has. And then the questioning and then examination of the traditional neurological exams. Can be hand clapping, can be walking, can be jumping, can be writing, can be naming animals. All these various things that are really what the tools neurologists have, which were developed and standardized. And they seem to be pretty solid tools to see what a patient is doing. One of the neurologists, there were two neurologists, senior neurologists in that room, were both brilliant. One of them was able to surmise what part of the brain might be affected purely by doing these examinations. It was like a living MRI. It was quite fascinating.
You mean from behavior?
From behavior. Yeah. Brilliant.
Wow.
Really brilliant. Yeah.
Yeah.
Yeah. Yeah. No, I was in the presence of great doctors. Really.
Yeah. Is it your sense that your mother had some sense that things were starting to slip away? I remember my stepmother had some dementia. It wasn't clear what the proper diagnosis was, but then I remember having a conversation with her. She was not a college-educated woman, but she had seen a NOVA program on how the brain works with the little neurons firing, and she remembered seeing like the little sparks between the gaps between my neurons, and I just feel like they're not working. She had a sense for a while things were starting to slip away, and she was trying to kind of hang on to them and figure out strategies to navigate that. And then at some point, it just got so she wasn't even aware anymore. Did you have that experience with your mom? And is that common for something like dementia?
Yes, for sure. She would get really upset if we told her she was wrong, because she thought, well, do you think I'm crazy? She would say, I'm not crazy. Right? That's what she would say. She was a very proud person and did not like to feel humiliated.
Yeah.
So it was a fine, act to try to figure out how to deal with some situations, for sure. I think that most people who have dementia in their family have experienced that. I think that's sure.
Yeah. So you also talk, again, back to the sense of self. There are philosophers and neuroscientists who think it's an illusion. There is no self. It's not in the pineal gland. You're not going to do a brain scan. Oh, it's right there. But okay, maybe it's an illusion like free will and agency, but, it's a powerful illusion. It works. And I do have a sense of who I am, and maybe it's fluid, it's flexible, it's changing. But I think of it as like you're in a fuzzy set, it's kind of fuzzy on the border, but there's kind of boundaries, or you're in a canal and there's walls, and you kind of bounce around and move around between the walls. But there's kind of a set of characteristics, a set of memories, a set of personality dimensions. I'm extroverted this level and I'm conscientious at that level. You go through the big five, something like that. And while it may change a little bit through the lifespan, it's fairly stable. And it may be my memories of being in high school or whatever. My 50th anniversary is coming up here for my high school reunion. It's like, maybe I've kind of distorted things, but I kind of have a general sense that that's who I was then. This is who I am now. And there's kind of a continuity to it, held together by those memories from one moment to the next. And isn't that a reasonable definition of the self? Yes.
I think William James, who's the psychologist, who really created scientific psychology in the States and elsewhere, who's returned to the fore now with all this new kind of psychology that's happening now, has a fantastic chapter on the self in the Principles of Psychology, 1890, which I love, a book I love. I love William James. And he has different kinds of ways of defining the self. I mean, one of them being, yes, all these various, certain beliefs and possession, even things, possessions are part of the self. Clothes, certain modes. And even my book on the Humours, I mean, in a sense, the Humours were supposed to also, your humoral portrait was a portrait of the self, even though there was no such concept as the self for most of the history of that. I think a lot of philosophers today are interested in especially in the tradition of phenomenology, are interested in using certain Buddhist conceptions of the self as actually an illusion, as you were saying before. And then there's Dan Zahavi, who's also a phenomenologist, who talks about a minimal self, and which corresponds broadly to what Damasio calls the core self. So those are different from the kinds of the kind of self, the autobiographical self that is dependent upon a continuity of memory. And you could say that you could say that there are these various levels as Damasio develops, and Self Comes to Mind is the book where he particularly develops this notion, right, from the core self. You have these other levels of selfhood, which bloom into consciousness and self-consciousness eventually. We define the self in relation to the other, and that's a very important notion. So we are much more than just the minimal or core self, which is that column, I think you're referring to, what you could refer to, a yogi would refer to, as I am to, as the breath, the central column of breath, I think is even a good image, which is real, I think. Which is not much of muchness, but it's basically our own sense of being alive. But the self is also just a notion of agency, that I am the author of my actions, and also of the body belongs to yourself. I'm having a block on the word, but that's a very important aspect of it as well. So that I am the author of the action, and that my actions actually are made by me. And those are those in a sense is this constantly, again, dynamic process of constant centralizing of everything we do by this thing we call the self. And I think the self is a process. I don't think it's a thing. I think everything's a process. And this philosopher John Dupre develops this very well as a philosopher of biology. And it's again an idea that's gaining traction. It's very useful, and it does rejoin in many ways some Eastern philosophies, like Taoism, certain aspects of Buddhism, not all. Some aspects of Hinduism are very complex, and it's another world. But it does rejoin those ideas that everything is a process, there's no substance. So I don't think the self is a substance. I think it is a process. And it is a process that is an outgrowth of these interoceptive mechanisms going on, which partake of our proprioception, that means of our self in space, and of exteroception, or perception of the outer world, interoception being the sense of our inner body. And that's when disturbances and interoceptive processes, which are these processes of correspondence of brain-body conversation, that then result in disturbances in the sense of self. And that's what's really interesting, what's being studied today. And so a lot. And so it's very, and again, I still think there can be, beyond these changes, and even in the case of memory problems, like in the case of dementia or what happened to my mom, there is a sense that there is a kind of basic physiological core self that does remain. I mean, in the case of Alzheimer, it does not seem to affect emotions so much at all, actually. And so there's a large aspect of the selfhood, which is maybe no longer very conscious, but that is, well, it's not meta-representation. We're not aware of having that particular kind of being, which is made of memories and so on, or of emotions. But those emotional core that my mother preserved in the case of my mom remained indeed part of her core self. So at a kind of basic level of selfhood. And of course, able to interact with me in an effective way. So no longer cognitively. So conversation was gone. I mean, we could no longer really have a conversation. So this kind of thing we're doing now, which we all do in the world of normality, was gone. I use the word at some point, I play with the word of executive, because this idea of executive system. So a lot of patients had what the doctors call dysexecutive syndrome. So meaning disturbances in this executive system, which is responsible for planning, indeed is pretty metacognitive, it's planning, putting things together, deriving meanings, and so on and so forth. There are debates as to actually whether that system should be called that. I put that in an end note, but that's a different story. But in a sense, I played with this idea of, we live in a world of executive diaries, right? We take for granted that we can plan our lives. We are professionals. We're doing things. We're capable. We tweet. We do. This is our life, right? And so when somebody's no longer able to have, when there's executive dysfunction, they're no longer part of the ordinary diary of humanity.
Right.
But emotionally, she's still there. Thank God she had an anosognosia. She wasn't aware that she'd lost these capacities. But she still could enjoy. There was still joy. There was still a lot of... And the primary emotion in her case was joy. In some patients, it can be different emotions, sadly. In her case, it was joy. She'd never been happier than she was during those especially last year of her life. And it's also owed to the fantastic carer she had, who I want to salute as well.
Right. I take it you would reject that kind of postmodern view of mental illness or brain disorders like this, say someone like Michel Foucault or Thomas Szasz, who argue that there's no such thing as mental illness. This is a social construct. It began in the 1500s or whatever date that was Michel Foucault announced as the start of mental illness. It's just society defining people as deviant and then locking them away, rather than, say, in the Middle Ages or before, they would have just been, quirky Uncle Sam, and he has these weird things, but he's part of our family and he fits in the community in some constructive way. What are your thoughts on that?
Oh gosh, it's really complicated. We need another hour and a half on that front. It's a great question. Well, all of them have been great questions. But all right, so sure. I mean, the category mental illness is definitely a constructed category. We do live with it. Now, it's not because the category is constructed that it's not real. It's the same issue with emotions as constructs, with Lisa Feldman Barrett saying everything's because we give names to emotions, that's all. No, it's not. I'm not a nominalist. Let's put it this way. I think there's a confusion here. You can perfectly well accept that there are cultural constructions to the way cultural interpretations to the categories we use. Sorry, that the categories we use are cultural interpretation, culturally conditioned interpretations of what we are experiencing. That does not mean that there is not something we are experiencing. So I'm not a nominalist. So I think there's something in between we can be here. I have the case in the book of a man I call Toussaint, this Haitian man. You might have had him in mind with this question, who comes in saying that he hears voices because he's been bewitched by people back home. And the doctors took very seriously his own interpretation because it was just as real as everything else. Medically, what was happening was something different, the two levels of interpretation. And certainly, I mean, it could be that some a witch could have helped him, but probably not. And this is where, I do draw a line. Because of course there is such a thing as scientific science and a scientific knowledge, and as which does give us a lot of insights into our biology and the rest of reality. So we do need to have to keep again, but again we return to the category of the pathology, Norman pathological. Georges Canguilhem was more of an influence on me. So there's obviously a connection between him and Foucault, but he was much more of an influence on me. And he wrote that book called Le Normal et le Pathologique, the normal and the pathological, which is precisely really trying to unpack, if you like, what what these two categories really represent, but not denying ever that there is such a thing as a pathology. And if you think about it, I mean, even in non-Western cultures, pathology is recognized as such. It might have a different name, but it's recognized as such. You have different ways of dealing with madness, but there is different various words for that. Outside the ordinary, right? Outside the groove. We have ways now of helping people who go, like in psychosis, which is also a Western term, of course, but we do have ways of helping. So I think it's important to acknowledge, actually, I do think it's important to acknowledge social constructions. I don't deny that. But I think we have to remember that it's a construction of something that is real. So that there is a very strong, I'm a scientific realist in this sense, right? A very strong scientific realist. And I think it can be very dangerous to use the fact that we have cultural and conditionings, that we are cultural beings, to use that as an excuse for relativism. That's also a philosophical conversation. I'm now involved. I have to resume a writing of a book that's quite late on the founder of cultural anthropology in America, Franz Boas. So I'm actually going from psychology now to anthropology. So I'm thinking very deeply now about these issues of culture and the mind. And actually, there's one anthropologist in Emory called Brad Shore who wrote a book called Culture and Mind, where he argues that actually Boas himself was responsible for reasons that inherent in his own extremely important agenda, for splitting apart psychology and the social sciences. So, and I think it's because of that split between biological reality, shared nervous system which that all humans share, and so on and so forth, and the social and social cultural diversity, that we have these problems, and that Foucault also came up with that issue. I think it's important to retrieve some of this, where these two areas meet, where the culture-nature dichotomy is a complete illusion, and it's a very dangerous one.
Mm-hmm. Mm-hmm. Yeah. Right. So to one culture, the patient presenting with symptoms looks like witchcraft. To another culture, it looks like demon possession. To a Western culture, it looks like a disorder of dopamine or whatever the neurochemical transmitter substance problem is, or whatever it is. But your point is that those all work in their different cultures. But if you actually want to treat the patient, burning women as witches or performing an exorcism is not going to be as effective as, say, giving the patient some medical treatment, an actual, kind of psychiatric medical treatment.
Yeah, I'm afraid so. I think it's the case. It's important to say this today when there's so many people believe all sorts of strange things about the vaccines. Yes. And the root cause of strange beliefs. You know something about that. And it's, again, the strange beliefs are a philosophical conundrum, but it's also a cultural phenomenon. And historically, it has its history, it has historical roots as well. There's always been these, right? But I think it is this rejection of this idea that science tells us anything other than what witchcraft tells us. Well, that's wrong. It's just simply not true. Right. And I think we have to.
I mentioned that abnormal psych course I took. This was at the time when Robert Rosenhan ran that kind of pseudo experiment in which he and his graduate students had themselves committed to mental hospitals in the United States, complaining of hearing voices. And then the task was, see if you can get out on your own, right? So most of them got in. They were diagnosed with some psychosis, he claimed. And then they had a hard time getting out, and that after they were admitted, he says, they acted perfectly normally. And the psychiatrists at these different hospitals supposedly diagnosed them with various disorders. Like one of them took a lot of notes. She was bored, so she was just taking notes about what the patients were doing and how the doctors were treating them and so on. And that she was then diagnosed with logorrhea, excessive writing behavior is presented by the patient. And another one was a painter. And so she's bored painting. And you can see in her paintings here, her neuroses is erupting in the color red or whatever it was. Okay, so I've written about that. I always thought it was a powerful statement on the power of words or diagnoses to misinterpret what somebody's doing. But now that study's been challenged, that he made up a lot of this stuff, and that maybe some of these people didn't actually even get into these mental hospitals, and the second part of the experiment may not have even been run, where he said, all right, I'm going to send some patients in, after these psychiatric hospitals complained about this study because it was pretty famous. And he didn't send any in, but they said that they did. And it's not even clear that happened. I don't know if you followed that whole story, but it gets down to that problem of diagnoses and the power of labels.
Yes, it does. I mean, it's a bit like the prison experiment.
Yes, Stanford prison experiment, right?
Yes, that's also been
yes.
shown to be. All these very kind of wow results are actually slightly.
Yeah.
It's been the case with quite a few of these historical studies. In a sense, too good to be true, right? I mean, to give such a
yes.
I think that, I mean, look, it's also true, however, I mean, again, we're returning to what we were saying before. I think in psychiatry particularly there is really a difficulty with understanding what is a pathology in psychiatry. I mean, I think there is a line beyond which there is such a thing. Of course there is. There are, just the same way there's a difference between ordinary kind of depressed state and clinical depression, where, I mean, I think the line really is where your difficulty is interfering with your daily life, quite simply. But again, even then, you can have a few days of not functioning and be okay again, and some people can get along quite well. Just some people who are highly neurotic or not particularly don't have a pathology, do make lots of mistakes in their lives because of their neuroses, but they still have lives. I mean, it's how do you evaluate how do you define normality? And this is where indeed you can use these questions, these Foucauldian questions, to try to interrogate it. But I think it's important not to become ideological about it, and to look at the cases as they come along. And it's true, labeling is problematic and complex, and precisely because labels change with knowledge, as they do in psychiatry, they do with neurology as well. And
a little bit like the medicalization of the concept of addiction. Like with the opioid crisis, you can see what the problem is directly, but then people say, well, I have a porn addiction, or I have a gambling addiction, or whatever, and it's like that. It doesn't seem quite the same. And yet, I suppose if your spouse leaves you, you lose your job, you're in prison, you probably have a problem, right? But people gamble or drink or watch porn or whatever, and they don't have a problem. They lead perfectly normal lives. So in that case, it's not an addiction, I guess. There, it seems like the fuzzy definition
it's really a fine line.
Different.
Yeah. It's again. I mean, you can't pathologize all human dysfunction. I think maybe that's what it comes down to. Right? Because then if you do that, then what is pathology, category pathology for? There's not much left beyond it.
Mm-hmm. Right, exactly.
Yeah.
Okay, I know you're on a tight timeline here, so let me just hit a couple of big topics. Consciousness, the hard problem of consciousness. Since you mentioned processes, is it your sense that consciousness is a process? So if you ask, well, where does it go under general anesthesia? Where does it go when during dementia, in dementia, whatever? And I guess your answer would be it doesn't go anywhere, because it's just a process that's slowing and then stops.
What can I presume to know? Right? I mean, I don't know more than anybody else. No, I do think it's a process, yes. And I think it's a process that is certainly extremely complex, that it's the outcome of a whole host of mechanisms that are, again, not just the brain, but the brain body. Just before this, I was actually listening to a researcher on subjectivity and interoception in Paris at the École Normale called Catherine Talon-Baudry, who was presenting some research on heart-brain and gut-brain interactions in the formation of subjectivity and consciousness. She was presenting that at the ICM, the Institut du Cerveau et de la Moelle Épinière, this major research and neurology institute in the Pitié-Salpêtrière, actually, as it happens, the same hospital where I was. And I'd actually talked to her when I wrote my piece for Eon on interoception. And she was just presenting this new data on how the brain does register changes in heart, and even in intestinal vibrations and so on, in all sorts of states. I mean, it's we really don't know. There's so much we don't know. I think consciousness is a biological phenomenon. I think that we share it with the rest of animals in some level. So there's all sorts of levels of consciousness. We have this. What is interesting when you mentioned to talk about the hard problem is that we have this extremely, it seems, unique capacity for metacognition, this awareness of being aware, this extremely refined symbolic language that we are discussing in now, creating concepts and so forth, developing technologies, building houses, doing things that other animals just don't do at all in the same way, creating art. So there are other versions of it in the animal kingdom, but it's not the same. I don't think it's a. The question is it a quantitative or a qualitative difference? And I think it may be more quantitative. Actually, no, I don't know. Sorry, no, I don't know. I don't know. I don't have an answer to this question. Again, there's so much, and every day there's new stuff coming out, new questions being asked. I think. Yes, I mean, actually, Catherine de Lombourry in her talk just before, she was also talking about, levels of animal consciousness. As long as you have a nervous system, something's happening. And there's an incremental level beyond which it's true we have then this shift into symbolic language. The philosopher Susan K. Langer, who was kind of forgotten, who was a wonderful philosopher, who talked about symbol making as central to all human life and to consciousness. And that's a very important idea as well, I think. And it comes back to what we were saying at the beginning, meaning making, where we need to create meaning. And we do that with our autobiographical memories. We do that with language. We do that with art. We do that with each other. And a very important idea also that I talk about and is part of the philosophical tradition I suppose partake of, is this idea that the self doesn't exist without the other, that we are from the very beginning, from conception onwards even, we exist thanks to another. We grow out of progressively separating ourselves from the mother, the carer. But given that we are, as infants, we are incapable of caring for our own homeostatic needs. We have to be constantly cared for. Therefore, and given that these homeostatic adjustments are exactly what interoception is signaling to us, these processes are outputs of homeostatic adjustments to a constantly changing environment. And given that as infants, we need our carers to provide these adjustments for us, because we can't, drink ourselves when we are thirsty and so on and so forth, or adjust our temperature. Our interoceptive processes are inherently social. So we are, as embodied physiological shelves, inherently social, which means that our conscious selves really is not locked in the brain as Descartes had it, but it really is about consciousness with others. When a person, and this is an idea that comes from the work of two psychologists in London whose work inspired me much, who are friends, two Manos Tsakiris, Katerina Fotopoulou and Manos Tsakiris, together wrote this paper on co-homeostasis, embodied homeostasis, which is exactly what this. Sorry, I'm actually forgetting the title of the paper right now, but it'll come back in a second. It's a very important paper that actually shows, and I cite it in the book as well, which shows which purports to show how this process has happened. So we are inherently social beings through and through, and that's an important, very, very important idea to always remember. We are, this 4E philosophy. We're embodied, embedded, enacting upon the environment. We are entirely within, constantly adapting within the changing environment, and this is how we are. Even our consciousness is maybe a function of those processes at work. So it's this is the thing. This is where you cannot go back to the Cartesian idea to talk about the consciousness. We're not locked inside our brains in that way. And I was going to say before, when a patient has some mental disorder, what is happening is that they're no longer able to interact in the same temporality as others. The sense of time itself depends upon these physiological processes. I talk about that too. What happens when somebody is very depressed, like clinically depressed. There is such a thing. When somebody is psychotic, when somebody is, they're divorced, their temporality is divorced from temporality of the rest of the world. It's like going back to this idea of the executive agenda. And that's really a profound thought. I mean, it's a profound realization. I mean, we are indexed on each other's temporalities. That's what we're doing all the time. We're doing it now. Infants do it with their mothers when they're born. Before we have language, we have, we sing song connections. We are rhythmic in a physical way. And that's what grows into then conscious states, I think. I mean, there's a continuum. Look, we're summarizing here tons of different theories and so on, and the work of many other people here. But yeah, which I acknowledge in the book, but I can't acknowledge them here. But my work depends, exactly as I'm demonstrating, depends on the work of all these other people.
Yeah. Yeah, that's maybe a good place to wrap it up, because it will take you to your next book, and we'll have you back on with that. So interoception, our kind of awareness of our bodies and ourselves. Exteroception, awareness of all that in interaction with other people. And then the environment, which I guess would be culture also. So your next study on anthropology, you're going to be asking these kind of deep questions. To what extent are we all alike, a universal human nature? But given those maps, internal maps and external maps and so on, there's got to be huge amounts of variation about the nature of self and consciousness and so on, depending very much on these radically different cultures.
Exactly. That's exactly what I have to do next.
Yeah. That sounds good. Well, I know you got a heart out here, and so I'm gonna sign off here. Really fascinating stuff. Beautifully written book. I just loved reading this book. It's great on audio too, by the way. The reader is quite good. And so we'll have you back on again when you finish the next book on Boas. I can't wait to read that. He's a very influential figure in 20th century social science.
Yeah. Well, this was great to talk to you. Really wonderful. Thank you so much.